Yeah, hello everyone. My name is Dr. Gauresh Palekar. I'm an orthopedic surgeon based in Mumbai and I have been in practice for the last 21 years. Out of this 21 years, for last more than 15 years, I have been associated with treatment of avascular necrosis of the femoral head. I think since you are listening to this video, I feel that you may have a special interest in avascular necrosis, which is a relatively unknown disease till now. However, because of the recent COVID pandemic, as well as steroid use during the pandemic, the incidence of this rare disease has unfortunately become much more common than it was before. Now, the first question that everybody will ask is, what is avascular necrosis? And what is the history of avascular necrosis? Now, avascular necrosis as a disease is thought to be because of loss of blood supply to this part of your hip bone. Now, this is the hip bone, and this round shape is known as the ball of the hip bone or the head of the hip bone. And there is a loss of blood supply to this particular area of the bone. Now, what happens is, if there is a loss of blood supply over a period of time, this round shape becomes flattened and it leads to arthritis. Once it leads to arthritis, the only option open for people is to get a hip replacement done, which is an artificial prosthesis which has to be inserted inside the hip like this, and then it functions like an artificial hip. This is basically what is avascular necrosis. Now, unfortunately, this avascular necrosis is very common in a relatively younger age group, and it is the commonest in somewhere around 20 to 40 age group, which is an age group where hip replacement is not the ideal treatment, and therefore we should always attempt to save the hip if it is possible. Now, regarding the history of avascular necrosis, it was basically like a lot of medical discoveries. It was discovered by accident. The people who discovered it were Fickett and Arlett, and these are the people who current classification of avascular necrosis, their name still carries on. Now, what happened is that they noticed, and you have to remember, in 1960s in France, there was there was only x-rays, there was no CT scan, there was no MRI. So the only way to diagnose things at that point of time was to do what is known as a biopsy, or take out a small piece of bone from inside here. So Fickett and Arley, they noticed that there were a very subset of group of people where the hip was getting spoiled badly, and they decided to do a biopsy to find out what was the cause of it, and they found dead bone inside, and therefore they basically they called it avascular necrosis, because they found dead bone and they assumed that this was because of lack of blood supply. In the next around 3 to 4 decades, this thought continued, and the way which they removed it is a process which is known as Codecompression, where to increase the blood supply, or initially to take a biopsy, what they had actually done was, what they had done was basically make a hole into the femur and take out a piece of bone. Now, this piece of bone, they found that people were having less pain after doing this procedure, and then they formalized this procedure, and therefore the treatment of avascular necrosis right for around 50 years then became this procedure which is known as Codecompression. That is, you take a drill to the femoral head from here, and then you take out the part of the bone, and this is what happens when you are, I'm sorry about that, I'm a little disturbed because of the phone, but this has been the treatment of avascular necrosis for the next 5 decades. In around 1980, right, American surgeon by the name of David Hungerford, he visited Paris to Fickett and Arley, and he learnt about this technique, and he was the first one to introduce it to the English speaking world. So from 1980 onwards, the name Codecompression was formalized by by David Hungerford. Initially it was called as forage, and now David Hungerford published extensively in English literature, and it became a process where he discovered decompression, and this process continued for the next 30 years or so. This is the historical basis of how avascular necrosis was discovered and what is Codecompression, how almost accidentally Codecompression started to be the treatment of choice for a lot of people, and how it has continued for a long period of time. Now, as I said, not a lot of people were very happy with Codecompression, because Codecompression as a treatment has not been universally successful. As a matter of fact, during my fellowship in America, I had an opportunity of working with the same Dr. David Hungerford, and during this time we had a lot of discussions about avascular necrosis, and it shaped a lot of my views also about avascular necrosis. But the surprising fact was that the person who had described the Codecompression procedure has given up on it because he felt that it was not working. So if Dr. Hungerford found that there was a large involvement of the femoral head, he would just go ahead and replace it, because he knew that Codecompression did not work. Now, around the year 2000, again, one French and one Belgian surgeon, Valéry Gangji and Hosier, these were the two people who started researching the avascular necrosis again. And what they did was that they did the forementioned Codecompression, but in addition to that, what they did was they removed the patient's bone marrow and they injected the bone marrow inside the femoral head. And they found that by doing this process, they found that the rate of failure of the femoral head went down a little bit, and they started investigation why this happened. They found that there were some special cells inside the bone marrow, and which were also simultaneously labeled as mesenchymal stem cells, and these are what are known as pluripotent stem cells. Now, what are pluripotent stem cells? They are basically cells which can turn into anything what the body desires. So for example, if the body desires a new bone, so they will turn into osteoblast. If the body desires new nerves, then they will turn into a neuroblast, and so on and so forth. So these are the cells which are present in all our bodies, and when injecting this bone marrow was done, these cells were causing some kind of repair inside the femoral head. They took this treatment further, and this from first generation of injection of untreated bone marrow, they then changed it into a procedure called as a BMAC, or bone marrow aspiration centrifuge. This BMAC procedure is what I call as a second generation orthobiological treatment, where what is done is that the bone marrow is harvested and it is minimally treated. Now, what is the minimal treatment? Is the bone marrow around 300 to 400 ml is taken out and it is put in a centrifuge. Now, by doing this centrifuge, what happens is that there is a concentration of these pluripotent stem cells or round cells into the part of the test tube. In addition to that, there are some other growth factors which have been found to be rich in this layer, and this is then injected into the femoral head to simulate new bone formation. So this is the treatment. It is known as BMAC, and it is available in India also right now. Now, the way I look at it, there are a few advantages of BMAC and there are a few disadvantages of BMAC. The main advantage of BMAC is that it is a relatively cheaper procedure according to me. The second thing is that there are some additional growth factors which are available in a centrifuge marrow. Okay. The main disadvantages of BMAC, the way I look at it, is that once there is a centrifuge, okay, nobody looks at the centrifuge material through a microscope. So we do not know exactly how many cells are getting injected into the femoral head, and therefore we cannot really quantify whether these are the cells which are going inside the patient's bone, and these many lakh cells or million cells are actually going inside. Actually, there are a few studies which shows that bone marrow aspiration wise only about 10,000 of mesenchymal stem cells are injected if you harvest around 400 to 500 ml of bone marrow, and that according to me is a very small figure to cause any significant change in the body. As we go ahead, and another disadvantage of BMAC is that it is in form of a liquid. So as you know that when you are injecting liquid, a lot of the liquid may spill over into the outside, and we are never really sure of the delivery mechanism of this BMAC. Then the third generation treatment has come in, and that is known as Osgro. It is introduced by a company called as Regro in India, and I have been associated with them not in any financial way, but as their user, and I was one of the first user for Regro, which is now almost around probably 12 years or so, and I did my first cases, and I was the first surgeon in India to use their product for this thing. And probably in the world also. I do have the largest series of patients treated by Regro, and that is the number which is still increasing, unfortunately. But what is Regro and what is Osgro, their product, or rather what is Osgro? So Osgro is basically what I call it as a third generation orthobiologic. Now, what is the difference between this versus the other generation is that we get a definite number of cells. So when we are using a Osgro product, we get around 50 million cells, which we know, quantified, looked under the microscope. And in addition to that, there is a good delivery mechanism whereby once we inject the Osgro inside, these cells get converted into a jelly, and this jelly does not flow back outside, and that is, I think, one of the biggest advantages. That is a definite delivery mechanism to this. Now, what happens? I mean, how does Osgro basically? How do we execute Osgro? So the first stage of Osgro is, like I said, bone marrow harvesting. It's a small procedure done under a small anesthesia, whereby only around 15 ml of marrow is taken out. Why such a small quantity? Because, as I will explain to you later, this marrow is then expanded. So this marrow is taken out, it is put in special tubes, and it is sent to the lab. At the lab, they isolate these mesenchymal stem cells, and they are then converted into osteoblasts. Now, what are osteoblasts? I know that you are hearing a lot of new things which you may find it difficult to pronounce, but osteoblasts are cells which form bone. It's simple as that. They are the only cells in the body which are responsible for bone forming, and that is what we require. So for bone healing, logical cells which is required is an osteoblast, simple and plain, because we have dead bone. That bone has to be replaced by live bone, and the live bone is produced in the body by only one type of cell, and that is known as the osteoblast. So we are injecting a final well differentiated cell line or a product inside the body. So this osteoblast, as I am saying, which initially there were very few, they are then expanded and multiply, and they are made into 50 million cells. Now 50 million is a huge number, okay? Now these 50 million cells are then injected into the femoral bone, and these cells will continue to multiply further and form new bone. And as they multiply, they also secrete certain cytokines, they are called as, or certain products which recruit more cells and help the other tissue to grow around that area. So this is basically the Osgro treatment of this thing. Now, how do we execute this? Like I said, in the first phase, what is done is the bone marrow harvesting. In the second phase, I'm going to use this bone model to show you. And what is done in the second phase is like this. See, this is the dead bone that I'm talking about in the femur. So this part of the bone is dead, right? Now, we have to access this bone, and I like to remove as much of this dead bone as possible to allow the new bone to form. So if you will see here, okay, there is a tunnel which is made like this. There's a tunnel. This tunnel is made to go inside the femoral head, and once this tunnel is made, there is a needle, and it will inject the bone here, and this area is filled up with Osgro. Now, this area has to be first created by curating out this kind of dead bone, and only then this there is enough space for these osgrow things to go in. Now, naturally, there are a lot of questions that I get when I propose this treatment to people, and I think everybody has come up, has got a right, and I try my best to answer these questions. Now, I will just try to answer a few questions which come on the top of my head. First question that anybody would ask me is that how successful is this treatment? Now, you have to understand that avascular necrosis as a treatment method, it has got very, very poor chances of recovery till now, because we did not know why this avascular necrosis happens. Even now, I'm not sure that there is 100% kind of confirmation about what is the reason for avascular necrosis. One thing is for sure, however, that it is definitely not because of only loss of blood supply. That theory, though loss of blood supply can cause avascular necrosis, that theory is basically discarded. Now there is a theory which says that in some people they are naturally more vulnerable to these avascular necrosis because of a multitude of factors, like having lesser stem cells or lesser reparative capacity, and a multitude of factors acting on the femoral head, like alcohol, steroid. This causes decreased reparation of the femoral head, and the femoral head, that is the reason why it dies. So that is the reason why world over it is not caused as avascular necrosis, but it is nowadays called as osteonecrosis or bone death rather than avascular necrosis, which means that bone death due to loss of blood supply. So like I was coming with to the answering the question, okay, what do you expect out of this? I feel that all those people that have operated where they have not yet developed a fracture, which is I think grade 2A, Fickett and Arlett classification, these are the ones who have not gone on to collapse further, or they have remained stable. And some of my patients are more than 10 years old now, 10 years from post surgery, and they have not required a total hip replacement. So I feel that is your best chance, that if we are able to do this process before the collapse set in, then I think that's ideal. However, once the collapse is set in, it is like a fracture of a glass, or once the glass is broken, you cannot really do anything to repair it. And over a period of time, your hip joint is going to get degenerated. I understand it, but I feel, and I have seen also in my experience, that the process of hip joint deterioration gets dramatically reduced. So if we look at literature, that is, literature is basically all those cases who have been done historically and they have been published. If you take a particular subset of avascular necrosis of people which are at very high risk of collapse, so involvement of more than 30% of the head, those people who have already developed a fracture, involvement of the weight bearing zone. Now there are multiple studies which show that the collapse of the femoral head will be there, and they will require total hip replacement within 2 years. Now I have got multiple patients who came to me after collapse, but the collapse was not a lot, and these patients have now finished around 7 to 8 years also, and they have not required total hip replacement. Whether they will require total hip replacement in the future, I do not know. Yes, there are changes on the X-ray, but for somebody who's a very young person, if I can give 10 years of their natural hip, I feel it is a better thing rather than, and probably I'm delaying their surgery, an additional surgery of a total hip replacement that they would require in their future life. So second question that I usually get is that whether these use of these stem cells are being associated with development of a cancer or something like that. Now you have to understand one thing, that these are your own cell line. These are your own cells. They are not from any other person. So that is number one. Second is that unlike stem cells, which are actually banned for in India, stem cell treatment, stem cell is banned treatment, while Osgrow is approved for treatment in India because it's a differentiated cell line. When I say differentiated cell line, it means that the final product, it cannot differentiate into anything else other than the bone cell. So it's a differentiated cell line. These kind of cancer and all does not happen. And now we have also published literature. We have done a study for asserting this more than 8 years ago, and all this thing is now it is a part of literature. Other than that, now the question remains that what is rehab? What is the rehab protocol for this? Unfortunately, when we are making a hole on this side of the femoral head, yeah, this hole is always at a risk of fracture, right? So for around 2 months, I prefer that my patients walk around with a walker so that they do not fracture. In addition to that, this hole that needs to get filled in completely. Till that happens, I prefer my patients to be on a walker. However, they need not be bedridden. They can move around, go to the toilet. Some of them who work nearby, they are also able to go to their office and work. People who are doing work from home, they are easily able to manage. So basically, this is the care that is required. No special medication is required according to me, and this I feel is a treatment that if you are or if you know somebody who is in the pre-collapse stage and I think they can benefit from this treatment. The final the thing that I question that I would raise is that whether all avascular necrosis requires surgery or whether it can be treated by medicine. Now again, we have to go back to literature, and literature tells us that there is a specific subgroup of people of avascular necrosis, and unfortunately this subgroup is the large majority. More than 80 to 90% fall into this subgroup, which requires surgery. And now, what are the ways in which you can find out whether you require surgery or again? First is that how much involvement of the femoral head is there. So this is the femoral head by MRI. How much involvement? As you can see, this is involved around 60 to 70%. So if it is more than 30%, you require surgery, because this is subgroup which does very poorly with medical treatment. Second criteria is whether it involves this weight bearing portion of the bone. So when there is a weight bearing dead bone, this would collapse. So second subgroup is that involvement of the weight bearing zone. Third subgroup is those patients who have already developed fracture, or there is a subchondral fracture which is known as crescent sign. That is a third subgroup where it is guaranteed that they are going to fail in this thing. Fourth are some technical parameters which only a doctor can look at, and that is how much is the involvement or the angle of necrosis, how much is the percentage involvement of the femoral head, what is the etiology or what is the basic cause of avascular necrosis. But basically these are the things that we look for before deciding whether to offer surgical or medical treatment. So friends, I hope that I have answered most of your questions, and this is a small attempt by me to educate and help out those